Everything is we are right on time.
So thank you everyone for joining us for the webinar on the theme lung cancer update. Without wasting any further time, it would give me great pleasure to introduce our chairperson for the session, Dr. Shyam Aggarwal, Senior Medical Oncologist from New Delhi. And I now invite Sir to please give the introduction and the context setting. Over to you, sir.
Thank you very much, and good evening to everyone who has joined for this lung cancer update here. Thanks to AstraZeneca for giving us this opportunity to get together for this international speaker program. So as you all know, we are focusing on lung cancer today, particularly the EGFR mutated non-small cell lung cancer. So we've come a long way in the last 3 decades or so from understanding of squamous and non-squamous lung cancer by way of doing immunohistochemistry. Then came the understanding at the molecular level of various subsets such as KRAS or ALK, ROS, BRAF, and of course, the foremost was the EGFR1. So I think it is very interesting to see and observe that, maybe about 5 years ago, we would say that EGFR mutants are only one disease. But now, with the understanding of molecular biology and new drugs, we really started dissecting out the various subsets in the EGFR mutant subgroup of lung cancer. And to that effect, we have the development of first generation, second generation, and third generation TKIs. And we've actually moved beyond that. We are talking of uncommon EGFR mutants. And then we are talking about antibodies, which are not only specific for EGFR particular mutation, but they are also targeting MET gene. So we're talking about drugs like Amivantamab and the newer kids on the block like Osimertinib and so on, which are now becoming available for targeting various genes and various subsets of EGFR mutation. So I think there's a long journey here, which we have undertaken in the last 2 decades. And I think we have exciting times to understand the nuances of EGFR mutation and the newer drugs which are now becoming available to target more specifically in a more potent fashion, which can cross the blood-brain barrier much more easily, and therefore use these drugs to improve the longevity and the quality of life. And of course, the understanding of the CNS involvement of EGFR mutants is there, and therefore the role of the latest third generation TKIs. So I think with this background, we can go into the lectures by our experts and the discussion which is going to follow on the patients with EGFR mutant lung cancer. So thanks again for this opportunity, and over to the organizers to invite the first speaker. Thank you very much.
Thank you so much, sir. With that, I would like to introduce our first speaker, Dr. Minish Jain, Senior Medical Oncologist from Pune, and he'll be talking on the topic NGS testing in lung cancer. With that, I'll hand over the mic to sir. Over to you, sir.
Good evening, everybody. I'll be discussing next generation sequencing testing in lung cancer. So NSCLC, as we know, has evolved as a disease, which was initially classified as a histological disease. Then we had molecular subtypings. And we now know that it is no longer one disease, but many in lung cancer. So next slide. Yeah, next. So evolution of lung cancer diagnostics has been from histology based to molecular diagnostics, and we are now treating mutation based treatments are now the norms for lung cancer. So it is no longer treated as one disease. Next slide. This is in past, we were treating empirically based on clinical pathological factors. We used to select the drugs for an individual patient. Then we had target-based treatments either on single gene or an NGS or a multiplex gene assays. So single gene markers, like you could do a Sanger sequencing, or you could do multiplex hotspots. And now we have next generation sequencing looking at DNAs or looking at RNAs. So if you are looking at DNAs, it is more specifically to look at the sensitive things like fusion abnormalities like ALK, ROS, RET, NTRK. And if you are looking at DNAs, then it's more looking at the insertions, point mutations, deletions like EGFR, KRAS, BRAF, HER2, and so on. Studies have shown to us that if patients are identified with actionable mutations, no, I think we have gone too ahead. Just go back to evolution of biomarkers. When I say next, then only change. Go back. Go back. Okay. So evolution studies have shown that if patients are treated with identified actionable mutations and appropriate treatment, the survival has improved 18.6 months versus 11.4 months, which was significant improvement because of this. And we also have now the future that is like plasma based or the ctDNA, which is going to be tomorrow, or we have already started using it today. So now we have three approaches when we are looking at a patient. Either we have a sequential approach, like you do the tissue based sequencing, or you do both together, the tissue and liquid, or you do the liquid testing first. So you can do either of these approaches, and patients can be then, and these are all complementary. So it's not like replacing one by other. Next slide. Yeah. So methods of biomarker analysis, we have histology earlier, then we had IHC, FISH. So the thing is, IHC and FISH are available to us very easily for ALK, ROS, NTRK, but the problem is false positivity and false negativity. And with NGS, we can target RNA, DNA. It is like you can either do an whole exome, you can do an whole genome, you can do an transcriptome, depending upon what you want, or the liquid biopsies, which are looking at the proteins, and which is the future, what we are talking about. Next slide. So these are the sequences which we have in market, and they're looking at, they're highly sensitive, looking at RNA, DNA, and they can target very little number of cells. The only problem is the people who are doing the feeding of these machines and the purity of the material, what you're feeding in. Next slide. So these are the molecular things which got approved. Like in 2009, we had Gefitinib for an EGFR mutation or deletion. In 2011, Crizotinib for an ALK gene fusion. Crizotinib again got an approval for ROS gene fusion in 2016. And Pembrolizumab also got an approval in 2016. We had Dafrafinib, Trambetinib for BRAF V600E in 2018, and Larotrectinib for NTRK, and recent additions have been Sulpercatinib for RET gene fusions and Capmatinib for exon 14 skipping mutation. So a lot of improvement in the drug, what we have been using for lung cancers in last, as Sir said, in last 2 decades, a huge change in lung cancer treatments. Next slide. So this is like either this is a model diagram of single gene testing. You can do an EGFR, ALK, or you can do a next generation testing all together, and then you will be able to know which drug to use for a particular patient. Next slide. So we have developed from the patient to one test or multi-targeted test and the right treatment for that particular patient. So one drug, one patient, that is what is the concept. And which one is the best drug? That is what we are trying to figure out with our technologies today. Next slide. So if you look at characterization of cancer genome, next slide. We have multiple things. We may look at point mutations, or we may look at chromosomal aberrations, which is like amplification or deletion, or we may look at translocation. And the current technologies to look at these point mutations are capillary sequencing, pyrosequencing, if you're looking at fish, IHC, these are the things, but the emerging technologies are parallel sequencing or massive parallel sequencing. Next slide. So looking at the cost, when we initially got the sequence done, human genome sequence in 2001, and the cost of a human genome in 2008 was 1 million, which came down to $10,000 in 2012, to $1,000 in 2014, and it is becoming cheaper and cheaper year on year. And with current scenario, it is becoming even more affordable to patients. Next slide. So this is how a NGS test works. Like you have a DNA fragmentation, library preparation, enrichment. Then you have a enriched library, which then aligns the exons. Alignment is done. Then there is a binary alignment map file, which is cleaned up. Then you are looking at the SNVs, indels, translocations. This is all fed to the VCF or variant call format files. And then there is a case sign out and report generation. So a lot of things go in. This is a very specialized technology requiring DNA, RNA preparation. There is a bottlenecking in this. There is a turnaround time to this. And it requires a lot of IT and data storage and cleanup of the files, what you have gone through with all these things. Next slide. So this is a process map of NGS, how things work. And this is a very complicated map which is shown here, but everything has to go through a quality check, and then it is passed for the next thing, and the final report comes in at a means it takes time, 2 to 3 weeks for doing all these things. Next slide. NGS, as we know, is a advantageous thing with a high thorough output. You can test many genes at a time. This is systematic, unbiased mutation detection. All mutations can be detected. You may look at SNVs, copy numbers, insertion, deletions, translocations, and this is a digital readout. So this is cost-effective precision medicine, right drug, right dose, right patient, right time. This is the advantage. But the problems are, like you may require pre-analytical issues are there, like you may require a formalin fixed tissue, which is proper age, proper temperature and processing. Fresh tissues may require a right kind of DNA identification, and fine needle aspirations may have very less of DNA of the right quantity. So these are some challenges. So you may have challenges with quality, quantity, or purity of material. And this is what may limit. So you may have to have a very good lab looking at all these things and getting a good results out of it. Next slide. So this is a paper which says that we require NGS in current lung cancer treatment. Next slide. One slide back. Okay. So there is a new study, which is Nautica, which is looking at basically ALK fusion, ROS, NTRK, BRAF, and RET mutation. And they are going to give the drugs for 8 weeks in operable lung cancers, which are like resectable 1A to 2B. And all these patients, after receiving 8 weeks of these targeted therapies according to the targets available, they will undergo surgery and then 4 cycles of chemotherapy followed by 2 years of the targeted drugs. And this study is going to get over in 2028, which will give us an idea of whether targeted drugs in early lung cancer is of help or not. So this is what is the study also looking at. So this is a very interesting study, and it is going to shift all our targeted drugs from metastatic setting to the neoadjuvant setting. We already have a EGFR drug in adjuvant setting. Next slide. So key takeaways, like biomarker testing in NSCLC has evolved from single gene to multiplex testing. New methods like NGS are showing immense promise. NGS panels helps looking at all actionable genes at a cost-effective and accurate way. Targeted cancer panels are useful for drug repurposing and small molecule inhibitors, and pre-analytical issues need to be handled if you want a good sample testing and results. Next slide. So Yeah, we've looked at this study. This is what is the study. Basically, I've already discussed 8 weeks of drug, then surgery, then 4 cycles and 2 years of drugs. To look at this, we require to wait till 2028. Next slide. So Sanger sequencing, this is a gold standard, which is looking at the multiplex ligation dependent probe amplification. There is a high accuracy, but it is a labor intensive, longer turnaround time, limited thorough output. But if you are looking at a single gene, this is great investigation. But next generation sequencing, there is a vast improvement in accuracy. It is a shorter turnaround time, high thorough output, and it is looking at the larger genomic rearrangements, basically. Next slide. So 3 key elements are required in NGS: the sample collection, wet lab, and dry lab. Next slide. So sample collection either could be a liquid biopsy, that is blood, or a tissue. Next slide. So the sample, if it is blood, you directly can do a DNA extraction, DNA analysis. And then if it is a tissue, then you require sample fixation, histopathologic review, tumor area identification, and then it goes to tumor DNA analysis, and so on. Next slide. If in the wet lab, you are looking at library preparation, sequencing, these are the sequences. And next slide. In the dry lab, you're doing sequence output, sequence alignment, sequence variant calling, and basically you are comparing it with your available. So there is a reference sequence and the output sequence, and then you are looking at the variants of clinical significance or variants of unknown significance, and then there is a report given out. So this is how the NGS data analysis and result interpretations are done. Next slide. Thank you.
Thank you so much, sir. If our audience has any questions for Dr. Jain, we request you to please put it on the chat box, and we request our expert to please take that. You can also raise your hand so we can unmute you. Okay, fair enough. Would request. I think sir has explained it very nicely, so we don't have any questions. We'll move on to our next session. Our esteemed speaker is Dr. Bivas, a senior medical oncologist from Kolkata, and he'll be talking on Osimertinib in early EGFR mutated non-small cell lung cancer patients, ADAURA. With that, I'll hand over the mic to sir.
Thank you. Thank you for the introduction, and thank you, AstraZeneca and the organizer, for giving me this opportunity. A very good evening to everybody. So after a beautiful lecture by Dr. Jain on the diagnostic and interpretation aspect of this complex molecular NGS, discussing on Osimertinib in early EGFR mutated advanced NSCLC in light of ADAURA data. So next slide, please. So you know that lung cancer, up to around 15 to 30% of the lung cancer get diagnosed in early stage. The incidence and the prevalence varies between the zonal difference or the different institute, but in general it is around 15 to 25 or 30%. So it is stage 1B to 2 and 3A, very rarely 3B, those who are resectable. And next slide, please. Next slide. So even after giving adjuvant chemotherapy, there are high chance of recurrence. So we know that after the 3 or 4 randomized trial and meta-analysis shows that the platinum-based adjuvant chemotherapy improves 5-year OS. The hazard ratio is 0.89, and DFS also with a hazard ratio of 0.84. And the magnitude of benefit is pretty prominent from stage 2 to stage 3A. There are debate exists in stage 1B. I think most of the clinicians, they don't prefer to use, and we also as institute don't advise adjuvant chemotherapy in 1B. But yes, from stage 2 to stage 3 resected is a pretty standard. And if you see this chart, this diagram, that even after giving adjuvant chemotherapy, the chance of recurrence is very high, as 45% chance of 5-year recurrence in stage 1B. Stage 2, it is 62%. In stage 3, it is 76%. That means even after giving adjuvant chemotherapy, 1 in 3 patient or 3 in 4 patient or almost 2 in 3 patient, they do recur in stage 2 to stage 3 resected lung cancer. So there is a huge unmet need to improve the outcome in those patients. Here comes the role of further therapy after the completion of adjuvant chemotherapy. Next slide, please. Next slide. So this is the current prevalence of EGFR mutations in NSCLC. We know at the rate in advanced lung cancer, it is in Caucasian, it is 10 to 20%. In Indian patients, it is around 40 to 45%. And in Far Eastern patients, it may be as high as 60%. And as for this data, there is not much of difference of EGFR mutation prevalence across the disease state. But I think the data is slightly maybe different in Indian setting also. We have seen that the EGFR mutation rate is hardly 10 to 15%, maybe 20% in early stage lung cancer. In comparison, the stage 4 disease, the EGFR mutation rate is approximately 40 to 45, even up to 50%. So there is a discrepancy, though in the US and the Europe, if you see in the Far East and the data, the EGFR mutation is not varying much as even if the disease progress or as per the stage of the disease. Next slide, please. So osimertinib is an adjuvant therapy in patient with stage 1B to 3A EGFR mutation positive NSCLC after complete tumor resection. This is the data or the trial of the ADAURA study. Next slide. Next slide, please. So coming to the trial design, we know about all the trial designs between stage 1B to stage 3A NSCLC patient after complete surgical resection with or without adjuvant chemotherapy has been enrolled in this study with a confirmed exon 19 or EGFR mutations. Brain imaging, if not complete preoperatively, has been done after surgery or before the trial entry. Complete resection with negative margin is mandatory for this trial entry. And if the patient received adjuvant chemotherapy, the window period of starting adjuvant chemotherapy was up to 26 weeks. If patient didn't receive adjuvant chemotherapy, the trial recommend that the drug has to be started within 10 weeks from surgery. Stratification by the stage of the disease, 1B versus 2A versus 3A, type of mutation, and race, the Asian and non-Asian. Randomized 1:1 design with osimertinib versus placebo, and treatment till disease recurrence or treatment completion or discontinuation criteria met. Primary endpoint is disease-free survival by investigator assessment in stage 2 to 3A, 2 and 3A. Rest were secondary endpoint, that is DFS in overall population, and DFS a deeper endpoint, and OS and safety and quality of life. Following an IDMC recommendation, the study was unblinded early due to difference in efficacy, higher or superior efficacy with osimertinib. Here it is the trial reports the unblind interim analysis. At the time of unblinding, study has completed enrollment and all patients were followed up for at least 1 year. So this is the inclusion criteria. All patients stage 1B to 3A EGFR mutation positive after completion of R0 resection. If they receive adjuvant chemotherapy or not receive adjuvant chemotherapy, was randomized osimertinib versus placebo with the confirmed mutations. And as I said, the imaging was done prior to surgery. If not done, they definitely has been done before the trial entry. Exclusion criteria, those patients who received pre-op chemotherapy or post-op radiotherapy or pre-op radiotherapy was excluded. And this is the timeline. If no adjuvant chemotherapy, 10 weeks maximum allowed from the time from surgery to randomization. If received chemotherapy, after 26 was allowed. Patient who has only segmentectomy or excision was not allowed, and other contraindication factor for osimertinib has been taken care of. Next slide, please. This is the baseline characteristic between the control and the study arm. If you see the EGFR mutation rate almost 55 and 45 by del 1985 later, but the important part is the adjuvant chemotherapy. In both the study arm, 40% patient didn't receive any adjuvant chemotherapy. I think most were in the stage 1B. Next slide. So this is the updated primary analysis of the primary endpoint. That is stage 2 to stage 3A DFS. If you see the hazard ratio 0.23, phenomenal. 70%, 7% reduction in disease recurrence, and the maturity of 51%. If you see the Kaplan-Meier curve, they start separating very early, and the delta is very prominent. At 4 years, the DFS was 29% in the placebo versus 70% in the study arm. Next slide. So this is another secondary endpoint. This is updated primarily in the overall population, that is stage 1B to 3A. Again, as a ratio, not much of difference, phenomenal, 0.27. And at 4 years, the recurrence disease-free survival is 38% versus 73%, almost double. Next slide, please. So this is the other secondary analysis of landmark DFS. If you see the 4-year DFS at stage 1B, hazard ratio is 0.41, stage 2 0.34, stage 3 0.28. So the magnitude of benefit is higher as the disease stays higher. That means the control of the disease, control of the microscopic disease is much prominent in stage 2 and stage 3. Still, if you see the stage 1B, 60% reduction in disease recurrence if you are using Osimertinib. That is also phenomenal, even for a stage 1 disease, where the 5-year recurrence studies can be as high as 45%. This is after 4 years. Next slide. This is the forest plot. It favors all the subgroup. Now come to the patient who did the last one, the patient who didn't receive adjuvant chemotherapy. As I said, 40% of the patient didn't receive adjuvant chemotherapy in either of the trial arm. If you see the hazard ratio 0.36, so that means even those patients who didn't receive adjuvant chemotherapy, whatever maybe the reason, mostly definitely it was a stage 1B population, still the hazard ratio is 0.36. In that group also, Osimertinib has a very good efficacy in terms of DFS. Next slide, please. This is the early overall survival curve. Definitely the data is not mature, only 5% maturity, hazard ratio 0.4. But in both of them, definitely the median OS is not reached. Patients and the investigator remain blinded to the treatment in order to facilitate assessment of the OS at the maturity. That means, though the study was unblinded, the idea is to unblinded, but the patient and the investigators were still blinded for the OS data, and they kept on the similar regimen. Next slide. This is the previous 5 randomized trial. Most few were phase 2, the small study, few were phase 3. In the adjuvant setting of EGFRm lung cancer after surgery, the DFS was benefit was there, but not OS benefit. Even the DFS benefit was not in that magnitude as like Moderator study. So these 3 studies, Select, Radiant, and Event study, was mostly from stage 1B to 3A, adjuvant Alotinib versus chemotherapy or placebo. The Select study 2-year DFS was 88% versus 76% of the placebo. And the Radiant study also, there was meaningful DFS benefit, and as far as the Event study, but none of the studies shows OS benefit. Coming to the another 2 study of adjuvant Gefitinib as compared to chemotherapy or placebo, there was DFS benefit, but no OS benefit. We have the mature data from the Sitong study, and also in the BR19 study, Gefitinib versus placebo after adjuvant chemo, no DFS and OS benefit. So all the 5 previous clinical trials, they either fail to show DFS benefit, or even if there is a DFS benefit, there is no OS benefit. And the magnitude of the DFS benefits was not at par as compared to the ADAURA study. Next slide, please. So another important part is the type of the recurrence, because type of the recurrence is important because we know that locoregional recurrence is the most common after post-surgery. But brain is a sanctuary site in lung cancer. You know that many patients of lung cancer either during follow-up or even when they diagnose in metastatic setting, 20 to 40% patient may diagnose with brain mets. So it's one of the sanctuary site, and when the patient develops brain mets, it affects the outcome, also the quality of life. So CNS is the common site for distal recurrence, especially in patients with EGFR mutant lung cancer. In the adjuvant Radiant study, 37% of the recurrence happen in the brain. Osimertinib has been shown to achieve clinically significant exposure in brain as compared to the other TKI, and shown very good intracranial efficacy. And we have the data from advanced NSCLC setting that it has a very good intracranial efficacy, and also it prevents CNS recurrence, and as compared to the first generation TKI. Next slide, please. So let's see how the type of recurrence affected and how it affects the outcome. 11% of the patient in the osimertinib has any terms of recurrence, and among the 11%, 60% recurrence is the local regional and 38% recurrence was distal recurrence. Now coming to the placebo arm, 46% was the recurrence rate, but if you see the types of recurrence, most recurrence happens in the brain, 61% versus 40% in the local regional. So that means, other than preventing a recurrence, the type of the recurrence, CNS, most of the CNS recurrence, that was reduced much more by osimertinib as compared to placebo. Why it is important? It improves. It involves the quality of life. It involves the outcome. Next slide. So this is the type of the recurrence. If you see the left on the osimertinib, the common site of recurrence was lung, lymph node, followed by CNS, only 6%. As compared to the placebo, the common site of recurrence was lung, 26%, lymph node 17%, and 11% was the CNS recurrence. So almost double as compared to the osimertinib. Next slide. So this is the updated CNS disease-free survival in patient with stage 2 to stage 3. If you see, overall 63 patients, 22 in the osimertinib arm and 40 on the placebo arm developed CNS events. And 3 patients were on treatment at the time of CNS recurrence with osimertinib versus 29 in placebo. This is the DFS rate, hazard ratio again phenomenal, 0.24. And even at the 4 years, the CNS disease-free survival was 75% versus 90%. So there are very few patients who did recurrence during on osimertinib. Next slide. Coming to the safety profile, I think we all know the safety profile of osimertinib. It's mostly the paronychia, skin rash, loose motion, and transaminitis. Now coming to the any possibly causal related AE, that means to the investigational agent, that is here is the osimertinib. Any AE was 91% versus 58% placebo arm. Grade 3 AE was 11% with osimertinib versus 2% with placebo. AE leading to death, there's no death in either of the arm. Any serious AE that is causing treatment interruption and discontinuation was only 3%. So definitely this is no new safety signal. Though few patients developed AE, but very frequently, very infrequently they require dose interruption. So dose interruption was in 27% in osimertinib arm because of any AE, and the most significant AE was only 3%. That is can be causal related to osimertinib. Next slide. So this is the all adverse event that is at least happen in more than 10% of the patient. Now the blue one is the osimertinib, and the deep blue one is osimertinib grade 3, grade 4. If you see, mostly it's the diarrhea and stomatitis, very few. And the placebo arm definitely very few patient has a side effect, not much of grade 3, grade 4 because they are not on any drugs. Q2 prolongation was reported in 9%. We know the common side effect with osimertinib. Next slide. Coming to the subgroup analysis, these are post-operative chemotherapy use and the outcomes of the ADAURA study. Next slide. So as I said, the 40% of the patient didn't receive adjuvant chemotherapy, and the majority of the patient received platinum. The 60% received platinum-based chemotherapy, mostly with stage 2 and stage 3, and few with stage 1B. So if you see, 26% of the stage 1B patient received adjuvant chemo, that means the rest 74% patient didn't receive adjuvant chemo, and among the 40% of the whole group, mostly a stage 1B. Here is the sub-classifications. Next slide, please. So this is Kaplan-Meier patient with adjuvant chemotherapy, without adjuvant chemotherapy. This is a whole population, that is stage 1B to stage 3A. Now coming to the DFS at 2 years, 49% versus 89% when patient is adjuvant chemotherapy. If you see the hazard ratio is 0.16. Now coming to the patient who didn't receive adjuvant chemotherapy, the hazard ratio was 0.23, almost similar. And if you see the 2 years rate, 58% versus 89%. So adjuvant chemotherapy didn't make any difference in the whole population. Maybe it make difference in stage 2 to stage 3. We'll go to that. Next slide. So this is patient with or without adjuvant chemotherapy disease-wise. Now coming to the stage 1B, the third one from there. So without adjuvant chemotherapy has a ratio 0.38, with adjuvant chemotherapy has a ratio 0.15. That is good. That means those patients who receive adjuvant chemotherapy has a better benefit with osimertinib in stage 1B. Coming to the stage 2, this is in stage 1B. Coming to the stage 2, with adjuvant chemo, the hazard ratio 0.15, without 0.2. Again, not much of difference, very slight difference. Stage 3A, again, not much of difference. With or without adjuvant chemotherapy, 0.13 versus 1. So that means in stage 2 and stage 3 disease, osimertinib is a very good efficacy in terms of DFS, irrespective of adjuvant chemo. That means adjuvant chemo failed to eradicate the microscopic metastatic disease, and osimertinib did the job. So a clinically meaningful DFS benefit with osimertinib was observed in patients with or without adjuvant chemotherapy, regardless of the disease state. That is the statement. Next slide. So DFS in patient with or without adjuvant chemo, as I said, this is stage 1B. Again, not much of difference. Next slide. Stage 2 we have seen, again, not much of difference. Hazard ratio 0.15 with adjuvant chemo, 0.2 without adjuvant chemo. Next slide. Stage 3A, if you see this curve, there is not any, you can't see any difference, 0.1, 3.1. So definitely hazard ratio 0.1 in a stage 3A. So osimertinib has very good effect in terms of DFS, controlling the micrometastatic disease. Next slide. Coming to the patient reported outcomes in ADAURA study. Next slide. So health-related quality of survey. So definitely, if you see the all types of health-related quality of life index. Next slide. Not much of a difference. That means patient didn't have whatever the AES happened due to osimertinib, it didn't affect the health-related quality of life as compared to placebo. Next slide. Again, time to deterioration of physical symptom or mental component, both no difference to placebo. Next slide. So to summarize, after this all updated data and the subanalysis in different aspects, including the quality of life, in this updated DFS analysis of osimertinib versus placebo, patients have been followed for further 2 years and all had the opportunity to complete 3 years of planned study treatment. There was a 77% reduction in the risk of disease recurrence or death with adjuvant osimertinib versus placebo, hazard ratio 0.23 in stage 2 and stage 3 patient after surgery without the adjuvant chemotherapy. Median DFS was 65.8 months in osimertinib, 21.9 months in placebo arm. There is also 73% reduction in risk of disease recurrence or death with adjuvant osimertinib versus placebo in whole population, including stage 1B. An improvement in DFS was seen regardless of whether the patient received prior adjuvant chemo or not. DFS benefit across disease stage was consistent following this staging based on the AJCC 8th edition manual. Osimertinib demonstrated clinically meaningful improvement in CNS DFS also. The safety profile was consistent with the established safety profile. No new safety was identified, and it didn't affect the quality of life. Median total duration of exposure to osimertinib was 35.8 months, near to 36 months. These updated data reinforce adjuvant osimertinib as the standard of care for patients with EGFR mutation stage 1B to 3 NSCLC after completing resection of the tumor with or without adjuvant chemotherapy. Next slide, please. I think this is my last slide. So thank you for your patient listening. I think if there are any questions, we can answer, or I think can be discussed in the next panel discussion. Thank you.
So due to want of time, can I request you to answer that in the chat box? And we'll
Sure,
move on to our next session. Thank you so much.
Yeah, thank you.
So we'll now move on to our next session. It gives me great pleasure to introduce our esteemed speaker, Dr. Mark D. Vincent, who is a professor of oncology at the University of Western Ontario, and he's also a consultant medical oncologist at the London Regional Cancer Program. He'll be talking on the topic, establishing the current therapeutic strategy in EGFR mutated non-small cell lung cancer in 2022. With that, I'll hand over the mic to Sir. Over to you, sir. Dr. Mark, your mic is muted. Can I request you to unmute your mics, sir?
Yeah, can you hear me now?
Yes, sir, we can hear you, sir.
Yeah. So, yes, thank you to AstraZeneca for making this possible, and good evening to all of you in India. It's morning here, but I'm going to be talking about EGFR, and very interesting to listen to the previous speakers. This is a rapidly evolving field. These are my disclosures, and much of this has been covered, so I can skip through some of this fairly quickly regarding the progress that's been made in respect of incremental ability to ascertain the driver mutations, along with the emergence of drugs to target them and generate very clinically meaningful responses and prolongation of survival. Although I think it's important to point out that we're not curing people with these drugs as yet, but the relative tolerability and the marked efficacy represents a major milestone in not only in medical oncology, but in science and medicine as well. So you've seen these slides illustrating the relative proportion of known driver mutations, but one little point to make is that it's still worth noting that there's a sizable chunk, more than 25% of this population in Western Europe and North America, at least, where we don't know what the actionable mutation or what the mutation is. And if you don't know what it is, obviously you can't design a drug against it. And the point has been made that if you have an actionable mutation, but you just treat people with chemotherapy, they don't do that well. So these are not benign diseases. These are quite aggressive cancers. But if you are able to access some kind of a targeted treatment, it's been known for at least 8 years or so that there's a very substantial improvement in these patients' survival. So it's important to get access, and this is an important theme that people are increasingly focusing on, because it's becoming clear that in much of the world, these non-smoker type oncogene-driven cancers are highly important, including in India. So just to focus on EGFR, we have a range of histological appearances that can be grouped together under the rubric of adenocarcinoma. And just to make the point that although we rely very heavily on genomic sequencing now, there is a clue that you can get, whether it's really worth pursuing. So if you have something that's, say, a solid cancer with mucin and so on, or it may not be driven by something that you can access in terms of a drug, although some of them may be KRAS driven. But if you have something that says papillary adenocarcinoma or micropapillary or cribriform, it's very worthwhile pushing the genomic screening, because you're quite likely to get something that's actionable, particularly the relationship of EGFR to papillary and micropapillary cancer. So in terms of the EGFR profile, we know that most of the EGFR mutations are these common deletion 19 and exon 21, but there's a big slice of about 15% in, at least in the West, that are related to the so-called atypical mutations, which include G719X and others. Exon 20 is really a different sort of animal, really, and responds to a different kind of drugs, and I really won't be talking about those, but I will mention a little bit later on in the talk the responsiveness of atypical EGFR mutations to, in particular, osimertinib and afatinib. So here's a cartoon of the EGFR receptor with the extracellular domain where the ligand is binding here, or the EGF in this case, at the transmembrane domain, and really where the action is in terms of the mutations in this region here between exon 18 and exon 21, really the so-called tyrosine kinase domain, which includes the ATP binding area, which of course can be blocked by these tyrosine kinase inhibitors. And there are some other cartoons here showing in a kind of linear fashion the EGFR gene, particularly this region here from exon 18 to exon, really even out to exon 22, where all of these important mutations are clustered, particularly deletion 19 and exon 21 in green. These are the common mutations, but you can see the location here of these atypical mutations, and some of which are very sensitive, such as L861Q, for example, and the G719S, and there are others, such as this S768I, which are really quite sensitive. So current options, we have a lot of drugs now. We have about 5 or 6 and more coming of these TKIs, first gen, second gen, third generation, and then the ability to combine them with either chemotherapy or a VEGF drug, and then other drugs such as savolitinib and so on, which we'll talk about as MET inhibitors. So there are now about 5 or 6 really good first-line studies with novel approaches. The sort of golden boy here for us has been FLORA, which has looked at osimertinib versus dealer's choice of erlotinib and gefitinib, and we'll show some data from that, showing really an excellent progression-free survival, 18.9 months versus 10.2, a great hazard ratio, and a spectacular survival. But there are other ways to skin this cat, for example, by combining a first generation with an anti-VEGF or anti-VEGFR agent. Afatinib and dacomitinib, really more toxic drugs, but really quite effective, but unfortunately more toxic. Just a point here that these studies have been done across the world with varying proportions of Caucasian versus Asian patients. We do know that Asian patients may tend to survive somewhat longer, and so that one has to be careful about cross-trial comparisons, because you do end up with a sort of apples and orange situation. So here's the widely accepted standard of care today. So, for example, in my country, osimertinib is a funded and available first-line drug for common mutations, followed by platinum pemetrexed. We generally don't use bevacizumab in this country, although I personally found it quite a useful drug to add on to chemotherapy if you can get it, but it's not funded. And then docetaxel as a third-line agent, and then best supportive care or palliative radiation therapy. I just want to emphasize that radiation therapy, particularly stereotactic radiation, can be inserted into any one of these lines of treatment, because it's really important to understand a lot of people have isolated foci of disease failure or symptoms, and these can be quite effectively treated with stereotactic radiation. So initially, I've just mentioned the first line, but osimertinib really came to light because of its ability to neutralize the T790M resistance mutation, which very frequently emerges on patients treated with afatinib, gefitinib, or erlotinib. And in my country, at least, osimertinib first became approved and available in the second line in patients who were T790M positive. And so this is just a cartoon that shows that osimertinib is really quite selective for the mutated EGFR. You can see that it has less affinity. I think it's wrong to say it has no affinity for the wild type. I mean, it is a drug that has some side effects, although it's a remarkably low incidence of side effects, but it has a much less affinity for wild type EGFR, much more selectivity for the mutation, but it's able to bind irrespective of the T790, whereas that is not the case with the first or second generation. And you can see why. You look at gefitinib here in the binding pocket, and you can see here is the normal T790 unmutated, and this side chain here can still bind in here without being sterically interfered with. But once you get this heavy bulky methionine that replaces the threonine at the 790 position, you can see that there's a steric interaction, and this tends to push the gefitinib out of the binding pocket, and the osimertinib design has been perfected so that there is no interference, so that even if you get a T790M mutation, it doesn't interfere. But of course, this is perfectly good also in patients that don't have the T790 mutation. It just means it works whether the T790 is there or not. In terms of mechanisms of resistance, it really depends on whether you're talking about in the first line or second line. But just to make the point that there's a lot of different types of resistance mechanism, but in this context of using first or second generation, the very high 50 to 60% frequency of the T790M resistance mutation means that this opens the door and the opportunity for drugs that can work irrespective of the T790, and of course osimertinib is one of these drugs, as illustrated in the AURA-3 study, which compared osimertinib to platinum pemetrexed chemotherapy in patients with T790M who had relapsed after first or second generation. And you can see here that there is a dramatic improvement in the progression-free survival. Again, this kind of staggering hazard ratio, way below 0.5, that really drives a change in practice, with the median PFS being about 10 compared to about 4. So, about a very massive increase. The problem with the second line, this seems to be a kind of a dream scenario, really. Why would we want to do anything different? The problem with the second line application of osimertinib is that if you look at this range of studies here, about 1 in 3 patients will not have access to second line because because of this high attrition, brain metastases, performance status deterioration, and so on. And only 2/3 of these patients treated in first line with a first or second gen will actually get to second line. And so this has led to this idea that you should get your best drug up front rather than at the back end. And of course, putting osimertinib in the second line requires a biopsy of some sort. We know that you can get ctDNA to some extent. It's not quite as sensitive, but it's not always available. And so for a lot of people, you're faced with having to establish the T790 situation with the second biopsy. And this is a burden all of us are busy. Our system really is pushed very hard now because people are living much longer and they're going from line to line to line. And so our system is pushed very, very hard right now. So we have to now think about biopsying people, the hazards, the patient inconvenience. Some patients will refuse. It engenders a delay. The timing is an issue. You need the sophisticated sequencing. Which tumor do you biopsy? You obviously only biopsy the one that you can access, but we know that some metastases have different mechanisms of resistance, and it may not be the right one that you're biopsying. But the liquid biopsy may be a solution to this to some extent. Now, what about osimertinib in the first line? And this is the FLORA study, which looked at the common mutations, deletion 1985R. These patients were randomized, a good performance status patients, randomized 1-to-1 between osimertinib and dealer's choice of gefitinib or erlotinib, and the endpoints here, PFS and overall survival, and a lot of translational work here as well. And here you see the primary endpoint of progression-free survival, again, a dramatic hazard ratio of 0.46, and here's the forest plot. All of these points and also all of the 95% confidence intervals are very shifted over to the left. And this includes patients who used to smoke, or whether they did or they didn't, Asians or non-Asians, and age, gender, and so on. And it's all very, very positive here for osimertinib. And you do see, and I want to emphasize this, that there is a great hazard ratio for both exon 19 deletion and L85R. So here is the survival, and the hazard ratio here is under 0.8. Of course, in the control arm, some of these people will have crossed over to osimertinib, but if osimertinib wasn't available, this gap would be even bigger. But there's a survival benefit, very worthwhile. Median survival really coming up more than 3 years in this patient population. CNS control is substantially better with the osimertinib compared to first or second gen. It's really, sorry, first gen. This was not a second gen trial. First generation. Hazard ratio 0.48. And you can see here the CNS response with a couple of complete responses really on the osimertinib, and the debulking within the central nervous system very substantially better. And I want to emphasize that it's not just about the formal partial remission rate. It's really about debulking. In the central nervous system, debulking is absolutely critical. So that even if you don't meet the threshold for a formal partial response, the fact that there's more debulking in general, I think is really, really important. In terms of the overall survival, big benefit for deletion 19, but less of a benefit for L858R. But I do want to emphasize that you still get a very substantial progression-free survival benefit in the 858R and a better CNS control and better quality of life. So I think this trial established, given looking at the toxicity here, less in the way of skin rash, less in the way of transaminitis, for example. But again, I think it's important to say it's not like there's no toxicity. There are a lot of patients who do get no toxicity or no significant toxicity, but you do have the ability to reduce from 80 milligrams down to 40 milligrams. And I find that some patients do better on 40 milligrams than 80 milligrams and don't seem to suffer as a result of that. And all of these criteria show improvement: PFS, time to first and time to second treatment, PFS2, and so on. It's really all in favor of the osimertinib. And this has persuaded both community physicians and academic groups to now incorporate osimertinib as an option. And I will make a point here that osimertinib is a preferred option in the NCCN guidelines in first line. So what are the attributes of this drug then? And I just want to make the point that osimertinib is, of course, the asset of AstraZeneca that is supporting this meeting. The attributes of osimertinib: superior PFS and OS compared to dealer's choice first gen, highly active against the T790, which is almost completely suppressed, outstanding CNS penetration, but without CNS side effects. And that's really very interesting. You get high levels of a drug in the CNS, but doesn't interfere with cognition or alertness. Less toxicity than other drugs, particularly than Ullas. It can be combined safely with VEGF inhibitors, but not immune checkpoint inhibitors. It's very important to understand that it is not possible to combine this drug with immune checkpoint inhibitors, and it's important to not to use it immediately after an immune checkpoint inhibitor, but to allow a bit of a washout because of the risk of pneumonitis. It's really an important caveat, and it may apply to EGFR inhibitors in general. It's probably safe to combine with radiotherapy, or at least to give it in close proximity to radiotherapy. And there's large international clinical trial. Now, what could change things? What could change things? For example, here's an interesting study from Japan, combining gefitinib with chemotherapy versus gefitinib alone, showing, again, a commensurate big benefit with the addition of chemotherapy in PFS and in overall survival. Asian patients, of course, survive longer in general, so I would caution against cross-trial comparisons in a crude way. But of course, you encounter now the toxicities and the inconvenience of intravenous chemotherapy. And of course, you do use up one line of treatment at the same time. So you use the first and the second line of treatment together at the same time. So there's a little bit of a concern about that. This is the Indian study, which of course was similar in design: gefitinib versus gefitinib plus pem-carbo, 1-to-1 randomization. Great improved PFS, highly statistically significant. Median survival is not yet reached. But of course, just to make the point that you're only doing 17 months here, and I think there may be differences between Asia and India with respect to the longevity of patients with this disease. And we know that Caucasian patients in general do not survive as well as East Asian patients. But again, here is the toxicity issue with chemotherapy. And so you have this kind of spectrum of studies. And really, in terms of the single agent monotherapy, we can see that really the FLORA data is, at least in terms of just the crude overall survival achievement, is somewhat better. We're interested to know what this is going to turn out to be with the Indian studies. But again, you're into the chemotherapy toxicity and inconvenience here. There's a lot of studies that have looked at combining EGFR inhibitors with VEGF blockade, and you can see them listed here. Here's the relay study of looking at Ullas with and without ramucirumab, showing a benefit by progression-free survival in both of the common mutations. Unfortunately, there does not seem to be a good role for osimertinib with bevacizumab. That's the bevacizumab with osimertinib in second line. But this was looked at in first line in a rather small study, interesting study in Japan, showing a PFS benefit in people who'd ever smoked. It's important to recognize that, we say this is a non-smoking disease. It is, but a lot of people who've used to smoke still can get an EGFR mutation. The fact that you used to smoke or still smoke doesn't stop you getting an EGFR mutation. So if you put up the piles of patients with smoking and non-smoking, at least in Canada, who have EGFR mutated lung cancer, numerically these are equivalent. So there's still a considerable number of people who have EGFR mutations, who have a history of smoking. It's not just the never smokers, But in these ever smokers, it seems that bevacizumab in first line did seem to add to the benefit. And this is just a small study, seeing about 30 or 20 patients. Also, deletion 19 seemed to do a bit better with the addition of bevacizumab. This is really a hypothesis generating thing. But you also see, interestingly, a lower incidence of pneumonitis with the bevacizumab. Does it protect you from pneumonitis? It's just a hypothesis. But of course, you do get a bit of hypertension with the bevacizumab. And of course, there's the cost of it as well. And so that's just the points that I made. So here's just a little bit of a focus down snapshot of the clinical trials program. We've heard about the ADAURA, really good presentation about adjuvant osimertinib. We're all very, very anxious to hear about what is the survival situation. But this is an indication that's funded now in my country, given the spectacular improvements. LAURA is looking at the application of osimertinib after stage 3 chemoradiation. And FLAURA2 is looking at osimertinib with and without chemotherapy. The ADAURA study has been very well presented, so I don't think I need to do that again, just except to put this up there, because this is like a masterpiece in the work of art. This is a staggering achievement and a massive benefit to people. FLAURA2, this is the design, osimertinib versus osimertinib plus platinum pemetrexed chemotherapy, and we're waiting to see what the result of this is. Now, as alluded by our chairman, there are substantial differences in the co-mutational profile. Some people have P53 mutations, some people don't. If you have a P53 mutation, it's really not good news. These people don't do as well. And it's maybe those people with the P53 that need the benefit of something else on top, such as, for example, chemotherapy. And maybe this will be a way to select who should get the chemo with the osimertinib and who can just get by with the osimertinib alone. The role of liquid biopsies, I've mentioned briefly. And it's important, it's great, and I think it's coming. It's going to massively influence a lot of what we do in oncology. Just a little bit to show that stereotactic radiotherapy in all kinds of patients with metastatic lung cancer is, I think, a highly important and is a tool that should be increasingly utilized, as illustrated in the study by Gomez, which showed that if you randomize patients with small volume oligometastatic disease to receive local treatment in addition to what else you're going to be doing, there is a very substantial and widening survival and PFS benefit. So I'll just mention that very briefly. What about the immune checkpoint inhibitors? The answer is it's probably they don't work. You can see here that in the EGFR mutated, this analysis shows that in these multiple studies that it's not really beneficial, unlike in EGFR wild type. And this is just another way of illustrating that in EGFR mutated versus wild type in Checkmate 169. There are some studies that, however, show the other, that there might be a benefit. For example, IMpower 150, which looked at atezolizumab type treatment, and they did have a small population of EGFR mutated patients, which suggested a bit of a benefit to the addition of atezolizumab. And unfortunately, in our country, this was felt not to be a big enough population, so we haven't approved this indication. Just about the immune side effects, when you combine this with EGFR inhibitors, including osimertinib, don't do it. Just be careful about that. What can we expect from conventional chemotherapy? Well, the answer is you can expect a response rates of 25 to 44%, a PFS from about 3 to about 6 months, and an overall survival ranging between 8 and 19 months. This is a randomized trial looking at pemetrexed or pemetrexed plus carboplatin, and you see the overall survival is a bit in favor of adding carboplatin, and that's generally what we do. What do we know about resistance? We know quite a lot that firstly, there are many, many, many different mechanisms. So it's not just like one size fits all as a solution to this in terms of osimertinib. But what has been observed in all lines is a C797S mutation in a small proportion of people, but amplifications especially of MET. And there are drugs now that can treat MET, but also histological transformations to small cell. You can treat that with platinum etoposide. Not that effective, by the way. So this is a bit of an unmet need. It's not very common. And there are mutations in the drug target. There's bypass signaling or mutations in the signaling mechanism downstream. With first-line osimertinib, the commonest known resistance mechanism, or the biggest chunk of it, is MET amplification. And here is the C797X, which might be sensitive to allotment, by the way. But the biggest druggable one is MET. There are others, of course, that we don't deal with. In terms of the comparator arm, MET amplification is only 4%, and the big one is T790. So osimertinib resistance, there's a lot of work being done on how to deal with this. There are some very interesting drugs here, which I'll talk about in just a little bit, but including MET drugs such as savolitinib. There are other MET inhibitors that have been alluded to, capmatinib, tepotinib, which are effective in the EGFR mutant population in combination with a continuation of the EGFR drugs, such as even in the context of gefitinib, for example, here with capmatinib, or osimertinib with savolitinib in patients resistant or who've never seen osimertinib before, including in the first line. So the Savannah study is going to be looking to see whether combination of savolitinib with osimertinib can overcome drug resistance in patients, particularly in patients identified by MET analysis as a biomarker. Now, amivantamab is a bispecific antibody against EGFR and MET, sort of interesting kind of hybrid antibody that can be given with lazertinib, which is another third generation EGFR TKI. And you see in these people who've developed resistance to osimertinib, a response rate that's really quite impressive, going up from 27% with amivantamab alone to 36% with the combination with lazertinib. And you can see this illustrated here with really quite impressive waterfall and spider plot. The response in patients who are MET amplified is much higher. So there's an enrichment strategy here where this drug might really settle as a place. There's a study, Mariposa, of comparing amivantamab and lazertinib versus osimertinib in first line, and we'll see what that shows. Patritumab deruxtecan is an antibody drug conjugate, which seems to be really quite effective post-osimertinib, about 40% against, and the antibody which delivers this drug, which is similar to irinotecan, is against HER3. Similar approach with TROP2, which is another cell surface antibody often expressed in these cells, and that can deliver these irinotecan type drugs with really quite an interesting response rate. Just to make the point that the NCCN recommends that you do not abandon the EGFR TKI just because somebody appears to have had disease progression, particularly in localized disease progression in the CNS or outside. You can often irradiate these people. You know, most of the disease still under control. You are allowed to keep going with osimertinib, and they recommend this very specifically. EGFR TKI rechallenge, and I'm just going to speed up here a little bit. And this is the benefit of docetaxel after a chemotherapy. Not necessarily EGFR TKI patients, but you can see it's about 10%. It's not great. I mean, it's not bad, but it's not great. And people have become interested in re-challenging with EGFR TKIs. There's a lot of anecdotal small studies showing that you do get some patients into response. Whether it was looked at formally with gefitinib first line, then chemo, then gefitinib re-challenge, you only see a response rate of about 5%. But a big chunk of patients get disease stabilization, about 50%. Median progression-free survival only 2.8, survival 10.2, not that great. But the idea is here is that the resistance to the TKI does not mean resistance to chemo, and then resistance to the second-line chemo does not mean resistance to the TKI, so that you can play kind of a sort of table tennis backwards and forwards kind of thing. And there are certain anecdotes within the literature which seem to be quite spectacular occasionally. So we've embraced this concept, and this is an investigator-initiated study that I'm leading together with one of my co-investigators across Canada in 10 centers called Ocelot, which looks at osimertinib in the first line, then platinum pemetrexed in the second line, and then re-challenge. This is the schema here, and basically we have now about 50 plus patients on the study, and we are looking at the objective response rate in third line, along with a lot of translational work, which we hope to publish eventually, looking at resistance mechanisms and seeing whether it can support this hypothesis of changing resistance mechanisms that can be wiped out by using different lines of treatment. So atypical mutations, I'll just mention, I think this list is familiar, but there are a lot of them. The G719, S768I, and L861, those are the important ones. They often occur either by themselves or in combination, either with a common or another uncommon one. Osimertinib, by the way, they can be grouped. I'm only going to be talking about group 1. And afatinib certainly can be effective in these patients, but again, it does come with a substantial amount of toxicity. And these are the blue here are these group 3 mutations. And you see the deeper the response, the longer the PFS. but we also have a little bit of data now from Osimertinib. Also, here's an afatinib up-to-date Frontiers Oncology recent paper showing you get about 12 months out of it with afatinib and about a 50% response rate. Osimertinib is effective as well. In these patients, there's a small data emerging data set, including our data set from Ocelot will allow atypicals to be on, and we have a response rate in these pure common, also the more common of the uncommon mutations of about 5 out of 7 documented so far. So really quite encouraging response rates on our study. So just finishing off here, as a possible future scenario, I think in future, Osimertinib will be given with platinum and pemetrexed in some people, not necessarily everybody. This is just purely my hypothesis, by the way. Okay, bevacizumab may be in the smokers, SBRT with oligometastases anywhere. Second line, amivantamab and lazertinib, at least maybe in the MET amplified, but possibly savolitinib. Patritumab deruxtecan or one of these antibody drug conjugates in third line, and then maybe docetaxel finally in fourth line. So that's just a hypothesis. It's completely my opinion. And basically, this is how the management might change over the next 5 years. And just to finish off, we know in your country from good epidemiological work done by your government institutions that EGFR is an important disease, particularly in men, but also women across many centers in your country. And we know that EGFR mutations are more common, I think, in India. Now we know with this emerging data than we had suspected, and more common than in the West. So this is really important. Certainly access to expensive drugs is an issue, but we know that CNS failure after first line with the first gen TKI, that isolated CNS or major CNS is an important thing, because these first gen don't really get well into the CNS, and this opens the door to Osimertinib. Now, Mr. Chairman, I'm in your hands. I can do a case report, or I can just end my presentation here. I'm in your hands, so thank you.
Dr. Pradyuman? Mr. Atul, should we continue with the...
Yeah, Kashish, maybe we continue with the agenda, maybe.
Okay. Thank you so much, sir. We'll now move on to the panel discussion. The panel discussion is on the topic management of advanced and early EGFR mutant non-small cell lung cancer. Our moderator is Dr. Ullas Batra, Senior Medical Oncologist from New Delhi. His panelists are Dr. Prashant Parmeshwaran from Kozhikode, Dr. Anita Ramesh from Chennai, Dr. Amit Sharma from Cuttack, Dr. Sandeep Kukkar from Mohali, Dr. Tanmoy Mondal from Kolkata, Dr. Srinivas Kulkarni from Pune, Dr. Venkata Pradeep Babu Koyala from Tezpur, and Dr. Rushabh Kothari from Ahmedabad. With that, I'll hand over the mic to Ullas.
Okay, that's nice. Good evening, everyone. And I exactly don't know what time is it there in Canada right now. What time is it, Professor Vincent?
It is 9:45 in the morning.
Oh, fantastic. So a very good morning to you.
Thank you.
And I'm sure you don't remember me, sir, but you are one of the persons who motivated me towards taking lung oncology in specific. I remember you once took a class on pemetrexed by Eli Lilly in Dubai and in Istanbul. And I was one of very young people at that time, and you were younger at that time, who attended the session. And I was very fascinated by the way you presented the pemetrexed data way back in 2009 and 2010. And the best thing is that your zeal and zest for teaching and the way your zeal and zest for presenting the data has remained the same. So hats off to you, and thank you, sir.
Well, thank you. Appreciate the compliments. Thank you very much.
So we will have a panel discussion on the EGFR mutant. Normally, when we speak about EGFR mutant, we typically talk about advanced lung cancer. But now I think we are going to talk about early lung cancer, advanced lung cancer. And I'm sure in 2 more years, we are going to talk about the LAURA and the new ADAURA also. So maybe the new adjuvant and the locally advanced also. But right now, we're going to talk about the adjuvant and the metastatic setting. So panel discussion on this, and what probably AstraZeneca wants us to discuss is like, yes, man, you say yes to Osimertinib in whatever form or other. But probably what we will really actually discuss is a balanced view for the benefit of all, because as Professor Vincent also said, Osimertinib is a good drug, but we need to combine it with something. We need to maybe give it or not give it, and maybe need to withhold our hold our horses sometime. So there are two sides to every story, and the truth lies somewhere in between. So let me start with I think we'll start with Venkat. So Venkat, let's start with the adjuvant lung cancer. You have, you have been treating lung cancer for a long time now. And can I also please request all my panelists to put on their videos, then it becomes easier for me to see. Venkat, can you please put on your video? Okay.
Sir, I'm traveling, sir.
So Venkat, what was your standard of care in a EGFR mutant non-small cell lung cancer prior to ADAURA? So the ADAURA came in 2020. So prior to that, if you had did you test for EGFR mutant non-small EGFR mutations in early stage lung cancer? And B, were you giving adjuvant TKIs in those people?
Sir, regarding testing, no, we are not testing EGFR during that time before ADAURA, and we are not giving any TKIs in the adjuvant.
Since you were not testing, you were not giving. Fantastic. Dr. Anita, you're always the first one to, to latch on to a new exciting concept. So what was your standard of practice at that time?
Yeah, previously, we never thought of, we didn't test also.
You didn't.
Did not do anything. Now with the new thought process, yes, EGFR mutation tested for adjuvant, which has shown good benefit.
Okay, Dr. Anita, your audio is not really coming up, but by the way, by the look of it, I am saying that you were not testing and you were not giving. Dr. Amit?
Yeah, not giving.
Dr. Amit?
Yes, no, at the pre-ADAURA time, we never used to do EGFR testing at that point of time, though we have very good DFS data even at that point of time, but we did not have any OS data. But none of us actually used at that point of time adjuvant.
Amit, I'm going to hold you on to it, okay? So just remember, you said you had DFS data, you did not have OS data, and you were not testing, you were not getting. I'm going to hold you on to this, okay? Just wait for some more time. Okay, Dr. Prashant, what about you? You're muted, I think. Yes, Dr. Prashant.
Can you hear me?
Yeah, we can hear you loud and clear.
Yeah, so we never used to test before in an adjuvant setting.
Is there anyone in my panelists who used to treat and you used to give? Okay, Professor Vincent, what was the practice in Canada?
Yeah, we just used chemotherapy. We didn't test initially in that time period. We've been testing reflexly now in everybody for the last couple of years, but not then. And we prefer to reserve these TKIs for metastatic disease. That was the consensus we came to.
Fantastic. So this was the data. I think there was a good amount of DFS advantage, as we can see in the Radiant trial. This was a phase 2 trial, which said that there was a subgroup analysis of EGFR mutant people, which had showed a DFS advantage, as everybody said. And this was an adjuvant study which had compared, and again, for people to understand, this trial compared Gefitinib versus chemotherapy. This was not Gefitinib in addition to chemotherapy, actually. So this was a study which basically compared Gefitinib versus chemotherapy, and the primary endpoint was DFS. And this was the data which was presented by Zhang et al. In Lancet Oncology, an HR of 0.60, which was fantastic. But then this data was presented at 2020 in ASCO, a similar time that the ADAURA was presented. This DFS did not translate into an OS advantage, and that is probably the reason why nobody was really testing for this. But can I ask you, I mean, if Dr. Srinivas, the median OS which has been there in this has been 75.5 versus 62.8. Typically, if you do not use a EGFR TKI, you actually don't get a median OS of this much in stage 1, 2, 3 also. I mean, you do not really get. So is this, was it a good sign, and could we have given, because, we all know there are a lot of people who will be lost to follow up. So, a median OS of 75.5 months in Jeff, 62.8, was it not good enough for you?
Yeah, so as you rightly said, the data came in 2020. And most of our discussion things were based on before the presentation of the data, in which early lung cancers we are not testing and we are not offering anything in the adjuvant setting. But yes, looking at the data, we would have definitely benefited some subset of the patients actually in the adjuvant setting. Looking at the overall survival figures, yes, I do agree that the data in 2020 came for osimertinib as well as these first generation TKIs. So I will still hold these figures important, because not each and everyone in our Indian context actually affords osimertinib per se. So in the given subset, yes, I'll still give importance to this data.
So I will come to the Indian subset of osimertinib over there. But then again, in this, there was no OS advantage. A 3-year DFS was also not significantly, and there was a high rate of CNS recurrence. Now that basically came about the ADAURA, and ADAURA was a study which compared osimertinib. This is again, we should remember, a patient could have taken chemotherapy, patient could not have taken chemotherapy. 25% of people did not take chemotherapy, but majority of them were in the early stage disease. So this compared after chemotherapy to osimertinib or placebo. Now that brings me to a question which I would like to ask Rishabh. Rishabh, 3 years, the magical number 3 years in ADAURA. How did that 3 years number came down to be? 5 years is breast cancer. Now 10 years is breast cancer. How did we arrive at the magical number of 3 years? Any guesses on that?
No, sir, I have no idea. I think that is a suspense, and
that
3
is a
years
suspense.
giving
Okay.
3 years osimertinib is not a joke in our country.
Fantastic. It is not to even think about 3 years and discuss about that is not a joke actually. Dr. Tanmay, you haven't spoken till now.
So yes, that's also, I also feel the same. We don't know the reason why 3 years, but yes, it's a joke in our country. That's right.
Okay,
Said by Dr.
So we all agree with the joke. We don't agree with the magical number.
So I feel so, Dr. Ullas, Dr. Prashant here. I feel I heard from ADAURA people telling that they took it, extrapolated from the gist, it feels.
Yes, you are right.
1 year imatinib and 3 years imatinib, 3 years did well. So they have reached a figure called 3.
You are absolutely right. And I think, yes.
Sir, 1 point from my side as well, Dr. Amit. One point, Dr. Prashant very well said that the ADAURA people tell. One other important thing is most of the patient who actually progressed or disease recurrence occurs on TKIs are basically after 2 or 3 years. So that maybe 3 is not even a number. Maybe they could have choose 5 years. Why not?
And
like time of living. Like time of
a lot of cost.
Sir,
and yes,
sir, in GIS they are already moving from 3 to 5.
Yes. So I mean,
so
Professor
Vincent
has put on his this thing. So Professor Vincent, your comments about 3 years, and then your comments.
Yeah. So I would, when you look at the CNS relapse, you do see that once you stop it at 3 years, not that long afterwards, that curve starts to go down in the CNS at least. Now you could say, well, maybe you can re-challenge these people with osimertinib, and we don't know about this. So our study Ocelot, I think, would be very interesting in the ADAURA setting, because when they relapse eventually, the whole question of re-challenge osimertinib is going to be interesting. But I just want to emphasize, the breast cancer thing went through, years of tamoxifen and, longer and longer and longer time on tamoxifen. So I actually anticipate it's about the 3-year thing is about the money when the money runs out. Yeah. So I think that 3 years, and given the dynamics of the failure, I think the company or the people who designed the study felt that 3 years would give them, enough of a benefit to get onto the market. And then the world will try and sort out whether it should be 3 years or 4 years or 5 years or whatever. And the ctDNA here is going to help us a lot. Should everybody get this? Some people are cured by surgery, right? So the ctDNA is they know that I think the ctDNA is going to narrow this market a bit. And then, but in the people who need it, it may need to be more than 3 years, and it may need to be indefinite. And of course, how we're going to cope with that is very interesting.
So I totally agree with Professor Vincent. I also spoke to the Astra people, and the 3 years was extrapolated from the GIST data for imatinib. Also because the Radiant and the adjuvant had given for 2 years, and they saw relapse coming at 3 years. So maybe they thought 3 years was good enough. The cost became a huge issue, in a trial. Even if your Astra, cost is a huge issue. and they wanted to get the drug into the market. And then very rightly said by Dr. Mark Vincent, the ctDNA, the MRD value, which person needs it, will also come into the point. So let me go to the results. I'll again go to Dr. Tanmay or Dr. Anita. Dr. Anita, results of this, impressive or not?
Yeah, definitely this results is very, very impressive. Okay, and we are all excited, and it is one of the landmark results in the last century has seen, where we in cancer, we have a TKI as an adjuvant therapy. I've seen in other cancers, but not in lung. And also one thing is that it's quite difficult also to get these early stages. So it's a real challenge. But then in a challenging condition, when the patient has come little early, why not give the best offer?
The best offer is what Dr. Anita Ramesh says, and she says it's a fantastic results of a century actually. I mean, that is what she says. Dr. Sandeep, agree, disagree?
Yeah, I think the results are quite impressive, but in the Indian context, I think we rarely see early stage cancers.
We will come to the Indian context early. Let's let's check the science.
So the results are impressive, and
so
particularly
let me just ask everyone. Okay, let me just ask everyone. Let's just keep the cost of Osimertinib, let's say 10,000 rupees or 15,000 rupees. Let's just get the science out of. Let's just get the commerce out of it. Let's get the science over here. And then we'll go ahead with it. The cost we will discuss later. When I still remember when docetaxel, Taxotere, when it was with Sanofi Aventis, how much was that docetaxel of 120 mg rupee at that time costed? It used to cost 1.2 lakh rupees. Zeloda, one tablet used to cost us 5,000 rupees. I've become slightly old right now. So, I mean, the cost was always huge at that time, but the cost is going to come down in some time. I think Anita will remember, Dr. Anita will remember. Let's just see the results. Let's just stick on to science. Impressive, Dr. Prashant? Not impressive.
No, my take will be, as of now, this DFS endpoint is impressive, but we have to wait for this OS for making it as a routine practice.
You will want to wait for the OS, okay? Dr. Amit?
Yes, sir. Sir, my point isn't it this trial is meant to be hit? I mean, they extrapolated we have very good data from the DFS data from previous first generation TKI as well. And this is, after all, is third generation TKI. And it has added benefit in CNS penetration. So isn't it DFS benefit is I'm almost expected with rather than 2 years, 3 years adjuvant targeted therapy. And at the same time, I mean, this is supposed to be, we should expect this sort of data even before starting the trial. The important thing is whether should we compare this trial design. I mean, we should make a new trial design with Osimertinib comparing with Zaftinib of a generation TKI so that we can sort out answer this particular question.
No, but Dr. Amit, you only said no, Zaftinib was not the standard of care. We all said, Zaftinib was not a good thing. We never.
But sir, our goalpost is changed right now. Now we are after looking at such a good DFS data. Our goalpost is changed. Not only the DFS, the patient's quality of life is very much improved with this particular tablet. So now this is the adding benefit of quality of life, less CNS less CNS mets, and if we combine all together, I think we should have a trial which should compare at least a Zaftinib or chemotherapy maybe, or maybe the chemotherapy with Zaftinib with Osimertinib.
I will totally agree with you. Can I just ask you a simple question? The DFS versus the OS, do you use AIs in breast cancer adjuvant treatment?
Yes.
Yes. What is the OS advantage of AIs over tamoxifen? And when big 98 and everything came, how much was the DFS and how much was the OS and DFS advantage? Didn't we all refer over jump to AIs, Femara and all?
Yes. This is, I know this question is going to be
that thing will always, we have spoken about it many times, but I totally agree with your point over there. Dr. Mark Vincent. Sir, whenever we discuss ADAURA, always the thing comes up, there's only a DFS advantage. We would want to see for the OS advantage. So what's your take on this, sir?
We think that the DFS advantage, even if there were no overall survival advantage, even if there were, that it's advantageous to patients to defer relapse, particularly in the central nervous system, but in general, so that when you get a benefit of this magnitude, then DFS becomes, I think, an important issue and an important endpoint by itself when you get this kind of magnitude of benefit that lasts for that long.
So what Dr. Vincent, what you're saying is DFS by itself may not have been great, but the amount of DFS advantage that we have got now is substantial, and living without disease is also very, very important. Is that what I'm getting from your side?
Yeah, because in Canada we don't hand out the money for nothing, right? So usually we say we've got to wait for survival. Usually that's the approach. But when the DFS magnitude is prolonged and of this size and this very large benefit for so long, I think it can tilt us to funding it early on in the adjuvant setting.
Okay, Venkat, I just saw your video getting on here. Your take on DFS and OS?
So as long as our information, when we are giving information to the patient, the most important concern is to prevent relapse in the adjuvant setting and to prevent the progression in metastatic setting. So in this early setting, if I can prevent the relapse by using a additional therapy, why not, sir? If the patient is having, as you said, when we keep the financial issues away, it is the choice, because and also it also shows that what we are giving as an adjuvant now is grossly inadequate. That is why
I think I would totally agree with Venkat. The point is your denominator right now. Again, that's what Dr. Vincent was saying. Your denominator, 75% of the stage 3 lung cancers will relapse. 60 or 55 to 60% of the stage 1 lung cancer will relapse. Same 60% of stage 2 will relapse. So whatever you're giving is grossly inadequate. There is definitely a case for giving adjuvant TKIs, but are we going to cure them out of their disease? That's an issue. As long as you tell the patient, and I'm going to come to that in a future time, and I would like to have Dr.
Sir, one small query from my side. Suppose if I counsel the patient for 3 years of osimertinib, telling him his disease will not recur early, and patient come back to me and patient will tell me, okay, what if after recurrence I will start osimertinib?
So Amit, I will just come to you in 2 minutes. I mean, these are slides that I had. So this slides, next few slides are for Professor Vincent, Dr. Vincent. So we all heard the presentation by Sanjay Popat. And this is something which I'm sure AstraZeneca didn't expect me to speak about, but I would like to have these slides, So these were the slides I have taken from ESMO 22 from Dr. Sanjay Popat, and what they're saying is that the moment you stop osimertinib, if you look at that, there is this thing which is coming up. There is this deaths which are basically occurring up. The moment you stop osimertinib, the disease looks like it is basically coming again. Also, if you can see over here, and this has been there for everyone, the moment you stop gefitinib at 2 years in adjuvant, the relapse increases. The moment you stop osimertinib at 3 years, the relapse increases. And this is what Dr. Vincent was referring to. This was basically the CNS disease recurrence. As you can see, in the control arm is absolutely here, but in the osimertinib arm, that is one with the light blue over here, if you can see over here, it is actually increasing. So the moment you stop osimertinib, your disease starts coming back again. Your CNS extracranial disease also starts coming again. So yes, there is an advantage. We are not delaying that. But is 3 years the right time? Maybe do we need to give it for 5 years? Do we need to give for 10 years? And as one of the panelists exactly said, and you said initially ctDNA, MRD, and is there something like we have to give for lifelong? So your take on that, Professor Vincent.
Yeah, I would predict that we will have to give it lifelong in certain patients, but we're going to be guided by the ctDNA. That's what I think. I think that, looking at those curves, you might say, well, why did we just do prophylactic cranial radiation, like in small cell, because of the high CNS relapse? The answer is you get dementia. I mean, people who live a long time, if we say on osimertinib or something, you're going to get dementia with whole brain radiation is not the solution, unfortunately. So I predict that, once it becomes cost effective, and I put this out to AstraZeneca, you might want to think about a costing model that allows people to continue. I mean, there's all kinds of models you can think of, and I hope you are thinking about this, that the 3 years is an arbitrary figure. It means the Earth goes around the sun 3 times. That's what happens, right? And that's when the money runs out. So at least in North America, that's when the money runs out. So I would say we're going to have patients on this for much longer. And I think we're going to imitate the breast. So I want to say one more thing quickly. The interesting thing about will we cure people is a very, very interesting question. Can you ever cure people with these kind of targeted drugs? Now, you look at the breast cancer setting in tamoxifen, and I look at those curves, it does seem never in the metastatic setting will you cure people with tamoxifen. You know, you prolong, but you never cure. In the adjuvant setting, you may cure a proportion of people with adjuvant tamoxifen, and then you stop. Is it possible that you might cure? And I may be interested to know what the breast cancer people think. Where can you, with say prolonged tamoxifen, and then you stop, can you cure people in the adjuvant setting? Is this adjuvant window when you can cure people? Does tamoxifen actually cure people? Because if so, it's possible that osimertinib might cure some people in the adjuvant setting, at which point it really changes the value proposition and the you know, the amount of money that was worth paying for cure as opposed to extension.
So I would absolutely agree with Professor Vincent. And to me, there is no doubt that the drug is effective. And there is no doubt that you will give the drug as early as possible. The only issue is we need to refine our patients about whom to give. There may be some people in which you do an MRD assay in which your the ctDNA is negative after 4 cycles of chemo, where you may not give. Maybe there is a course of giving it after 3 years when you have got it done over there, where you can stop the treatment. So we need to, so there is no doubt the drug is effective, but we need to further personalize the treatment and then only come over there. The earth revolves around the sun every month, Dr. Vincent, in India. The cost of osimertinib in India is hugely prohibitive. So, but the point is that yes, the drug to me should be given in the adjuvant setting. The costing, the DFS advantage, further refinement is something which we need to really consider. Till that, even living without disease is not a very bad option, because we also know that patients, you know, again, we have looked at our data, people who have got surgery done and then gotten chemotherapy done, 40% of them will never come back to you. 10 to 15% of them will come back with brain mets to you and they will not take treatment. So, you know, when you take all these things, you have to look at the larger picture also over there. How many people will get brain mets and have a seizure and then come back? And, you know, when I started my practice of oncology, I think Vincent will remember, we used to give chemotherapy to everybody in 2015 also, because there was no OS advantage. Then suddenly one guy with EGFR mutant NSCLC died who had not taken a TKI. And we said it is criminal. It is criminal for a patient of EGFR mutant NSCLC to die without taking a TKI. That was a game changer moment for me. And I said, forget the chemotherapy. I'm going to give them all oral TKIs. And that is where the survival has improved. So I'm sure you do require EGFR TKIs in the adjuvant setting. How much, when, how long is a question that we still need to understand more. That is what, I mean, Professor Vincent, am I right? Or if you want to add anything?
No, I think that's right. I mean, I think one of the other interesting questions here is, do you even need the surgery? You know, so some patients are very, very, I have to know surgeons here, but, you know, some patients are borderline operable, you know, and can you get away with just maybe stereotactic radiation and then the osimertinib? So, you know, this is a nice little defined data set, but there's extrapolations here in the kind of penumbra about, you know, how we're going to use this drug fairly creatively.
Okay. So, Professor Vincent, I mean, I think we just have 5 more minutes to go and you have a busy morning. The last one, the unblinding issue in ADAURA trial. I'm sure everybody wants to hear it from you. You know, so what does the unblinding actually mean? You know, does it mean that the investigators are unblinded, the patients are unblinded, AstraZeneca is unblinded? Who is unblinded right now? And what does it mean for the patient? Professor Vincent, this is for you.
Yeah. So we haven't faced the situation pragmatically speaking, and maybe you can summarize what the rules are around the study. But to me, you know, because of the interest around re-challenge that we have, it's critically important, I think, to know, you know, which arm patients received or not. So I would say there's a bit of an ethical obligation to actually unblind individual patients if and when they relapse, because if they've had a placebo, you know what the treatment should be, versus if they've had osimertinib and they relapsed, say, and now, you know, when they finished 2 months ago or on osimertinib, you know, the treatment's completely different.
Prashant is reading it. Prashant, you're asking me a question or trying to read that in
No,
figure out what exactly is
I was just reading that. No
okay,
question.
because you were reading it as if I prepare for my exams. But the point is, the idea over here is not everybody who was in the placebo arm will get osimertinib on this thing. So, I mean, AstraZeneca, there is no clarity. I mean, please correct me if I'm wrong, if there's a clarity or not, but there is no clarity that everybody on the placebo arm will get osimertinib. So, we are not yet sure about that also. Venkat or Prashant, again to you. Will you give EGFR? Let's say you have a exon 18 mutation, adjuvant osimertinib, yes or no?
I think so. No.
Okay, I also think so. No. So I will not give. Till now, the approval is only in the adjuvant setting is for DEL19 and exon 21 mutation. So I would also not really give over there. This is an easy one, Dr. Srinivas. Somebody got a surgery done, NSCLC, PD-L1 90%, EGFR mutant. What would you give, ADAURA or Empower or nothing?
I will wait.
You will wait. Oh, you are still waiting. You will not. Will you give atezolizumab? Okay, that is what I want to know.
No.
Okay, so fantastic. The benefit of gain which is there. So I would definitely not give immunotherapy. Whether you want to give osimertinib or not, that depends upon which school of the thought you actually belong to. This is something which was there. This is what I think Professor Vincent was talking about. How will you manage the progression on adjuvant osimertinib arm in ADAURA? Progression while in osimertinib is simple. Probably you will give chemotherapy. Less than 6 months, 6 to 12 months, more than 12 months, and just in case you think your job sucked or sitting in the panel sucked, look at the person whose job is this. Prashant, more than 12 months after osimertinib, how will you want to treat this patient?
No, I was just reading an article. Basically, they tell that whenever you give a drug for some time and you stop, and when you try to re-challenge, majority of the clones which come back is something called a drug-resistant clones, it seems. So that is one thing they're telling for 3 years of osimertinib, and you're again going to re-challenge osimertinib after 1 year.
That is what Professor Vincent is trying to do in the, that's a fantastic one. Although I would like to share Dr. Vincent, and I'm sure Venkat has an article on that. Venkat, we presented a case report where we gave afatinib after osimertinib, and it did work very, very well. In fact, Dr. Vincent, in India, we do re-challenge them very much often, more often because of none of the option is available. So if you're given a first generation, you give chemotherapy, we do go back to first and second one. I was just thinking we don't have a randomized control trial, but I have a series of at least 40-50 patients, and we do get around 4 to 5 months of PFS. That's just something which comes on the back of my mind.
I would encourage you to publish it.
I would. I mean, I was about to think about that. I would want to do that. So maybe Venkat and you and I can take on that. So Professor Vincent, would you want to, based on your data, somebody who relapses 6 to 12 months after osimertinib, how would you want to treat?
I think, if you've got the patient's not deteriorating rapidly and so on and so forth, but you've got a little bit of a window of opportunity, and you can get access to it, I would say a trial of therapy, short-term trial of therapy. One strategy that I use that I find very, very effective is that you don't give something and wait for 3 months to do a CT scan, because it's not a good idea. If you measure CEA, CA99, and CA125 in the blood, and do a chest X-ray or something, or so quick clinic, within 1 week, you can know if they're going to benefit or not. You shouldn't wait 2-3 months for a repeat CT scan, because if it's not going to work, you're going to lose the patient. Yeah. You can find out in 1 week. So I want to champion this idea of a trial of therapy in any situation where there's a blood biomarker. CEA costs $10. I don't know what in your country, but it's very cheap. CEA, CA99, CA125. Most patients, almost all patients with this disease will elevate at least one of those markers. So we think colon, it's pancreas, ovary. No, these are very useful markers in lung cancer, adenocarcinoma, and especially EGFR. You can get a very quick readout within 1 week. What's going to happen?
Okay. This is for Amit. So Amit, if osimertinib is not available, will you look at the first and second generation TKIs? I'm sure Professor Vincent is smiling not at this, he's smiling at the simile that I have presented over here. So what will you give gefitinib and erlotinib and afatinib? I know it's an Astra symposium, but still, will you give that?
If it is you're talking about adjuvant setting, sir?
Yes,
or,
I'm talking about adjuvant setting.
Adjuvant setting.
You said no initially. You can't go back now. Okay.
I will
Yes or
pass.
no? You will pass. Prashant?
No, I still give maximum the CTOM data I tell to my patient that I give just in it.
Sir, we know that there is Indian jugaad for everything, the costlier thing.
Don't
So if
even
we-
think about that. Don't even think. It's all in the news. Don't even think about it. I'm telling you, don't even think. In Delhi, there is a huge thing going on. Don't even think about the B word in Osimertinib.
so chemo plus first generation, like in metastatic, which has showed excellent data, maybe if we do not have access to osimertinib in major TEF settings, then maybe
You will.
yes, sir.
Okay. Srinivas?
Yeah. So earlier I told you that I'll still give importance to that particular gefitinib or erlotinib thing, even though the DFS benefit was not there even at the end of 3 years. So yes, I'm for it.
Okay. Dr. Rishabh?
No, sir, I won't give first or second generation.
Anita?
Yes, plus I think none of the studies with erlotinib, gefitinib was able to reproduce this data what we have got with osimertinib. So scientifically, we don't have academic or any support to give it. But then in country like India, if you're EGFR positive, and yes, if you want the patient to live, yes, I might.
You might give.
I
give. Think, you know, what has happened is that after the ADAURA data, people have started loving gefitinib even more. I think, you know. Okay, Dr. Sandeep.
Yeah, in the medical college, I would be attempted to do so when I'm in the medical college.
Okay, Dr. Sandeep.
Sir, I will.
You will. Okay. Dr. Tanmay.
Sir, I will not give the first or the second generation. I would wait.
Dr. Vincent is the final word in this. Dr. Vincent, yes or no?
Yeah, I mean, if you've got no alternative option, I think you can discuss it with your patient. I think you're really obliged to discuss it with the patient. You know, if you think that you can access it, you know, do you discuss stuff that you can't access with patients? You know, that's very difficult ethically. We argue about this all the time. In our country, we will have access to osimertinib, fortunately. So that's probably what we'll use. It's funded now, I think. So we'll be able to use that.
It will be far more easier to send a patient to Canada, sir, and get original osimertinib for our people, you know. Okay. So these are the pros and cons of ADAURA that we have said about, and that's going to be my last slide. And I think we've already discussed what we'll do on 26th November. I think adjuvant osimertinib, I'll just summarize and stop right now. I'm not going to discuss advanced NSCLC. I think there is definitely a place for adjuvant osimertinib. What, how much, when there is it's something which we need to discuss. Thank you all my panelists. Thank you, Professor Vincent, for being an absolute sport, and again learned a lot from the dedication and the interest that you have still, and the clarity of thought and the with which you think and you express your ideas.
So can I just say I've learned a lot from you guys with my involvement with India over the years. I've been extremely impressed by the quality of people, by the quality of the science, the quality of how you care for patients, and the deep thought you put into these questions in a country with differential access. Very, very interesting indeed. And I've really valued this interaction. Thank you so much.
Thank you. Thank you. And with this, I hand it over back to the organizers. Thank you all my panelists. Thank you, Professor Vincent. It has been a fantastic journey. And I really hope next time we meet Professor Vincent in India, we will really have a clarity of thought about adjuvant setting, which one to add chemotherapy, which one to add ramucirumab, which one to in a co-mutation, whether to give adjuvant setting or not. But it's fantastic. It's very exciting to practice thoracic medical oncology right now in India. Thank you. And back to the organizers. Thank you.
Thank you so much, Ullas sir. Thank you, Mark sir, and thank you to all our panelists and our speakers. And a big thank you to AstraZeneca. So on behalf of the Integrated Academic Society of Clinical Oncology, we thank everyone. And with that, we come to a close of the session. Thank you, everyone.
Thank you.